Hello, everyone. Welcome to our Zoom meeting. Today, we're going to have a couple of items in the agenda. So we are looking forward to the speakers. Dr. Wissam will be the moderator. Dr. Wissam, please go ahead when you are ready.
Okay, hello, Dr. Nader. Hello, fellows. Thank you for being here today. Inshallah, today the session we will have several presentation. We will start with a presentation about addiction. Dr. Mohammed Makkawi, um, you can start if you're ready.
Hello everyone, my name is Dr. Mohammed Makkawi. I'll be doing my presentation on addiction. Just let me share my screen. Okay, hello everyone, my name is Dr. Mohammed Makkawi. I will be giving my presentation about addiction. So here basically we're going to talk about how to define substance use disorders and how much is it a problem, what are the risks, and especially in the older group, older adults, and then how we define it and what kind of magnitude it is, and how to identify them and manage them. So, what about substance abuse in older adults? So, it's actually common and it's a major public health issue. It's actually a two-pronged issue. It's a problem because usually in elderly group they are more prone to mental health conditions such as depression. That itself is a fuel to lead to drug substance abuse. Furthermore, even the substance abuse itself also further channels the problem of mental health. So it's actually a two-pronged issue. Another problem in the physical sense is that they are more prone to the cognitive and physical effects of these substances. So it's important that we should be able to identify them and provide appropriate treatment for older adults. So there's a pro in the diagnostic criteria. It may be difficult to apply it to the elderly group. So because usually they have some problem when it comes to recognizing them. For example, in older adults, they are less often diagnosed with alcohol abuse compared to their younger counterparts. So this mainly because usually the elder group, they will drink alone at home, so they're less likely to be arrested and they have difficulties in employment. And there are also many healthcare conditions that can be associated with substance use, such as hypertension and stroke. So in the DSM-5, previously when I was in medical school, they used to teach us terminology such as substance abuse and substance dependence. But no longer now from DSM-5, it's no longer used. So it's mainly diagnosed by using criteria, which includes impaired control, social impairment, if there is any risky use, or if there is any pharmacological criteria. Previously, legal issues was criteria where if there is any issues with the police or with any force of law, then it will be considered, but now it's no longer considered. So they usually, so all the experts, they advocate for screening to identify those with risk, or at least those who are at risk or problem use. The best way is to do that is to use interventions where we try to determine the quality, the frequency, and the consequences of substance use rather than using formal diagnostic interviews. Then we have the substance. We also try when we are doing the interview with them to avoid stigmatizing language, like saying words like addiction or alcoholism. It makes the patient less likely to open up to us. Then, when it comes to substance abuse, we're going to talk about some risk of classes. First, we have the at-risk use. So here, any use of substance at a quantity that is greater than the recommended level is known as at-risk use. So recommended upper limit for the elderly is no more than one standard drink per day, or no more than two drink or episodes of binge drinking in a 3-month period. And for females, they have a lower threshold of more than 2 drinks, and for men, more than 3 drinks. Then there is the problem use. In problem use is when there's consumption of an abusable substance that may result in at least one problem related to its use. For example, when we use benzodiazepines already used by a patient who already has a pre-existing unsteady gait, which may lead to increased risk of falls. Then there is the low risk and moderate use risk. Low risk, those that falls within the recommended guidelines for consumption and is not associated with problems. For elderly adults, if they consume within the recommended drinking guidelines, which we have mentioned previously, or those who are able to reasonably limit their alcohol consumption, for like such that they are not completely dependent, or that they do not drink if they plan to drive or operate a vehicle, and also is not associated with any problem. For example, taking more than what is prescribed or supplementing it with illicitly prescribed substances. If there is any change in physical or prescription medication, they can even increase the low risk to a problem level. Then we have abstinence. Abstinence is defined as no illicit drug use over the past year. So it is very important for us to assess past use patterns. So we should also be able to determine what could be the reason for this abstinence. It could be due to any recent illness or a previous history of substance use. So he may have a problem with a substance that prevented him from taking the substance over a period of 1 year. So illicit drug use, actually its prevalence is starting to increase, especially over the last 20 years. And the survey shows that nearly 470,000 adults, they use an illicit substance in the last month. This does not reflect misuse of prescribed medications, which is actually the second most common form of substance use in older adults. So we're going to talk briefly about the prescription medication misuse. Here, when there is inappropriate use of prescription or over-the-counter medications like sedatives, hypnotics, narcotic analgesics, and surveys show that more than 60% of adults are taking an analgesic, 22% are taking a CNS medication, and 11% are taking a benzodiazepine. So why is this a concern? Because these medications, they have potential to cause tolerance, withdrawal symptoms, and harmful cognitive changes. They also cause medical diseases such as kidney, liver failure, and increase in morbidity and mortality. In recent years, there has been rapid use of opioid, especially when patients dealing with chronic pain. So during the last few years, there has been ninefold increase in opioid and benzodiazepine prescription, and with rates increasing, especially higher among women, and increasing with age. So medications which are used by adults in order to treat this problem, they have to be monitored, and we have to regularly check up, reevaluate them every 3 to 6 months. And we should be careful when we are prescribing multiple medications to avoid potential hazardous interaction. And only in the patients where specific target symptoms and documented response to treatment, we should be continue to prescribe this medication. If there is no response or only a partial response, then we should reevaluate the diagnosis and the further care. Now we're going to talk about the most common substance misuse. It's alcohol. So nearly 2 to 4% have alcohol abuse and more than a heavy drinker. And 10 to 22 are daily drinkers, with 31 to 58% with risk of abstinence. So the prevalence is actually much higher in older men than older women. Among the young, usually it's the females who are presented more. Similar patterns are also seen with illicit drug use, except with benzodiazepines, which are actually seen more commonly in females than men. So in the clinical settings, The prevalence rate of alcohol problems is actually higher in the hospital than in the community dwellers. Usually, what we see is in the hospital, sometimes the patient will present would be someone who is chronically dependent on alcohol, be drinking a lot. Once he gets admitted, then after 1 day or maybe 2 days, he may develop withdrawal symptoms. So that would be our first clue to understand that actually he has an alcohol substance abuse. That's why it's really important to screen all the others for substance abuse whenever we get the chance in the medical setting. Substance abuse also has a very clear and profound effects on health, and they also have adverse effects on self-esteem and coping skills. So it can be, which can be actually aggravated, especially if they have social issue. For example, they may have a recent loss of a loved one. So this may aggravate such issues. So there is some things we should keep in mind regarding what disabilities the substance abuse can cause. If an elderly patient consumes more than 7 drinks a week, there is an increased risk of stroke from bleeding with impaired driving skills and increased risk of injuries such as falls. And also in female, especially in females, the increase of risk of breast cancer actually is 50% more than those who drink less than 3 drinks a week. Then alcohol also has many harmful interactions with many drugs prescribed or over the counter, such as benzodiazepines and antidepressants, which may cause further drowsiness, or it can also interfere with the metabolism of warfarin, which many of these patients may be on. And this risk is furthermore with those who take an average of more than 4 drinks a day, or those who are diagnosed with alcohol dependence. So usually the most common physical problems they include alcohol liver disease, COPD, peptic ulcer disease, and psoriasis. They may also cause unexplained multi-system disease. So we have to be careful and try to pick out if the patient has any history of alcohol use. Then there are also other substances. They can also cause excessive physical disability. For example, smoking, they cause increased risk of pulmonary disease, especially cancer. And benzodiazepines, like we mentioned earlier, they can cause excessive physical disabilities with increased risk of falls with driving impairment. Excess physical disability can, especially in the older age, there may be difference in the pharmacokinetics ability of the patient. So they can the medications that they take may stay longer in their bodies and can cause increase in drug interactions, which can compound adverse effects. This may lead to either lethal or non-lethal overdose, and which with an increased incidence of dependence. That's why the FDA has actually recommended new guidelines so that when it comes to the long-term prescription of opioids, we should be very careful regarding prescribing them. Then mental health problems. Older adults usually, if they're more likely to have a lifelong diagnosis of another mental disorder. Usually, alcohol is implicated when it comes to mood disorders or suicide or dementia. Usually, those with alcoholism and depression, they have a more complicated clinical course and with an increased risk of suicide and social dysfunction. Benzodiazepines may provide dramatic short-term relief for anxiety disorder. Hence, it may be used in a short term to treat anxiety disorder. However, in long term, there is concern for both paradoxical worsening of anxiety as well as development of withdrawal tolerance and withdrawal symptoms. So sometimes we prescribe them for insomnia. However, if they're used in a long term, they may worsen the insomnia symptoms due to development of tolerance and withdrawal. And unfortunately, these effects may persist for months even after discontinuation of the benzodiazepine. Then we have alcohol-related dementia. So here, patients who have alcohol-related dementia who become abstinent may not show a progression in cognitive impairment. comparable to those with Alzheimer's disease. Alcoholism by itself is known to lead to a syndrome of dementia, and there may be some hypotheses which may implicate glutamatergic toxicity, but the mechanism is still not well understood. Then, clinical features, they may include end organ damage. Usually, the heart is greatly affected. One of the most common issues is, as you know, dilated cardiomyopathy. Then there may be cognitive stabilization or improvement after abstinence, and the evidence of cerebellar atrophy if you do a brain imaging. So, what are the risk factors for substance abuse? Usually, they'll be the more affluent individuals, like those who are more well off, white, then female sex. Usually, they're more associated with prescription drug abuse. Then smokers, there is a strong association between someone who smoke and drinking alcohol. And then those who had a history of substance use disorder and exposure to drugs of abuse potential, like opiates. Then those who are socially isolated, those who divorce, or those who have a decreased social interaction. Then involuntary retirement after it. Usually this after retirement they may increase the risk of binge drinking. So how do we identify substance use disorder? The most important thing that we have is clinical examination. Then there are some screening instruments that we can use, which can increase the sensitivity, such as Michigan alcoholism screen testing, which is known as MAS. For the elderly, we have a special geriatric version. Then we have Odyssey, and then the famous cage questionnaire, which can be used as a screening tool. Then there are some lab tests that can be done. For example, if you can find microcytic anemia and thrombocytopenia and elevated gamma glutamate transferase, then you may need to do further screening. Then most of the illicit drugs, they can be detected by using urine drug screens as well as prescription drug use. So what are these screening instruments? One of them is called the MAS-G, consists of 24 questions that are scored. Those who the score is more of 5 or more shows that there is a potential alcohol problem and need for further assessment. Like for example, if does alcohol make you sleepy when you fall asleep in your chair while when talking to others? Do you ever underestimate how much you actually drink? So why do we use it? Because it has a high sensitivity and specificity for identifying alcohol misuse, especially in middle age and older adults. Then we have the Odyssey. It's a 3-item screening that is scored. Usually, the higher the score, the more likely that the drinking is affecting the patient's safety. How we ask them 3 questions: How often do you take a drink containing alcohol in the last year? How many drinks do you have in a typical day? How often do you have 6 or more drinks on one occasion over the last year? Then we have the KHA questionnaire, consists of 4 questions. We ask them, have you tried to cut down on your drinking? Have you got annoyed at anyone who is criticizing your drinking? Do you ever feel guilty about your drinking? Have you ever had any eye opener to steady your nerves or to get rid of a hangover? A positive answer, if you have 1 or more yes, it means that there is a problem drinking. And it has high sensitivity but low for alcohol dependence, but not for at-risk drinking. So finally, how do we treat it? The most important thing about treating is to engage the patient in the intervention. If the patient himself is not aware that it's an issue, it's a problem, and if he's not is not on board in doing the treatment, then this treatment may fail. So what interventions can we do? Prevention and education for those who are low risk or abstinent, minimal advice or brief structured interventions for at risk, and formalized substance treatment for those who fulfill the criteria for substance use disorders. So formal treatments, they include psychotherapy, education, rehabilitation, and psychopharmacologic agents. Those elderly patients who are engaged in treatment, they have shown to have very robust improvement, especially when compared to younger cohorts. Long-term treatment programs actually increase the likelihood of their success. So management for those on long-term opioids or benzodiazepines, they actually can be challenging because they develop dependence. So if you abruptly discontinue them, they may go end up with rebound symptoms and rupture of therapeutic alliance. So it cannot be assumed that geriatric patients cannot be discontinued from long-term benzodiazepines or opioids. So here we try to why are they receiving this medication? For example, if they are receiving the long-term opioids due to pain, sometimes a referral to a pain specialist may help with providing a non-opioid or maybe non-pharmacological intervention to manage his pain. And an office-based treatment can be done for opioid use disorders. Then detoxification and stabilization. We're going to first we're going to assess the patient by history, examination, and labs. And then we should remember that some of the substances, if you abruptly stop, may cause severe withdrawal, especially from the alcohol, and it can be actually life-threatening. So such patients with severe symptoms of dependency or withdrawal can have significant medical or psychiatric comorbidity and may require inpatient hospitalization for stabilization. Then inpatient is actually achieved by if you're keeping the patient on the minimal amount of drug that helps to suppress the withdrawal symptoms, and then we decrease the dose by 10% every 3 half-lives of the drug. And we prefer to use longer acting formulations. Like we have methadone, which is a long acting partial agonist of opioids. For patients, those who are hospitalized for elective surgery, we have to be vigilant for any evidence of withdrawal. Then some symptoms regarding alcohol withdrawal. Early symptoms, usually they occur within the first 24 hours. They may have tachycardia, diaphoresis, or tremulousness, and it may progress to overt delirium, psychosis, and seizures. So for these patients, we try to give them oral benzodiazepines, and if needed, we may need to give IV lorazepam. For those in the outpatient management, we try to go for peer-specific group activities because they're shown to be more superior compared to mixed age. Like we try to put elderly with other fellow elderly patients. Usually they'll be more interactive with them, and it's shown to be more successful. And usually it needs to address issues of leisure time and social activity. And we should also be supportive as a physicians. We should commend them if they cut as much, even as small as if they manage to decrease the usual dose from, for example, 5 milligram to just 4 milligram. That's for them. That's actually a great achievement. So we should commend them for it. And this is especially true when it comes to medications such as benzodiazepines. Then there are some brief interventions, low intensity brief interventions. They are very cost effective, especially for those who are at risk and problem drinking. There are some studies, two randomized controlled trials. They show that older adults can be engaged in brief intervention protocols, and they're acceptable to this population, which led to a substantial risk in drinking among the at-risk drinkers receiving the intervention compared to the control group. Then the pharmacotherapy. Medications usually they may be of benefit, but it's not very well studied. For example, in alcohol use, the American Psychiatric Association they recommend using naltrexone or acamprosate. SSRIs are shown to be not effective in reducing alcohol misuse, but they can be used if the patient has concurrent depression. Comorbid medical and psychiatric disorders must be identified and properly treated as well. Then some principles that we can use in treating younger patients, they can be also applied. For example, benzodiazepines are very important in treating alcohol detoxification, but they have no place in maintaining long-term abstinence. Disulfiram may benefit well-motivated patients. Remember that with the medication, in order for it to work, the patient should take the medication continuously, so that so that if he drinks, he will develop the side effects such as flushing and sweating and diaphoresis. But if the patient knows that that as long as I don't take this medication, I can drink and I won't have the effects, then he can just ignore the medication and just continue to drink, so it won't be of any benefit. So disulfiram used can be only be used in those who are well motivated and those who wish to stop it. Then methadone maintenance can be used shown in opioid use disorders. Especially, it can be used in the elderly, and they can be maintained on dosing regimen, following the same principles in younger patients. Then nicotine. Nicotine is actually one of the most main issues, because it's a chronic disease and requires multiple attempts to quit. If you're very familiar with the stages of change, it's actually started and it was described from smoking. So, in order for usually a person to be successful in quitting smoking, usually may require multiple attempts. Then, why do we emphasize it? This because with smoking cessation at any age will slow the decline in lung function. And even if you're discussing it with a very old patient, even those who are 85 and above, it's still shown to be very beneficial. So to prepare to quit, we have to discuss management strategies, set a quit date, and implement a monitoring plan to maintain success. Pharmacologic substitution with nicotine patch or gum can be done with followed by gradual decrease in the dose. In multiple trials, antidepressants improve rate of continued abstinence, but only bupropion has been shown is FDA approved for nicotine substance. Then there is also a drug known as varenicline. It is FDA approved and shows strong evidence for for smoking cessation in younger adults. But it carries a black box warning because of neuropsychiatric symptoms, and patients should be counseled prior to starting this medication. Then psychotherapy with pharmacotherapy has been shown to be superior to just pharmacotherapy. Then there are some brief interventions at each office visit we can promote. Yeah, like it's our duty as especially those who are in the primary care physician. It's our duty to always target those who are at risk. So we do a screening test known as the 5 A's. Assess if the patient has any nicotine use and readiness to quit and advice to quit, and assist them in the quit attempts, and then arrange both a quit date and a follow-up visit. Then we're going to talk about other forms of addiction which is not related to medications. Gambling. So gambling especially is an issue with older adults because they engage in compulsive gambling behavior, and especially those who have been engaging it from earlier in life, they will continue this pattern of destructive behavior. Gambling in late life, both recreational and problematic, has been shown to be associated with higher prevalence of both mental and physical health problems, with many adults reporting that gambling is a means of coping with loneliness and boredom. So, during the history taking, we're going to ask about if there is any problematic gambling, if they're preoccupied with it, or they're restless when they try to quit, loss of control, and they need to bet more money with increased frequency, and continuation of gambling despite negative social and occupational consequences. And during this time, we should also screen for alcohol abuse, smoking, or other substance abuse. Unfortunately, there is no single medication that has been shown to help in reducing pathologic gambling behavior. So we're going to mainly focus on community resources and 12-step programs. So to summarize everything that we have been talking until now, older adults are particularly vulnerable to the effects of alcohol, psychoactive medications, and drugs. And the misuse of prescriptions and over-the-counter medications is actually more common among older adults. Clinical exam is the most valuable tool in identifying them, and cognitive impairment from chronic alcoholism may improve with sustained abstinence. All the adults involved in treatment with very robust improvements have been shown to be more successful, especially compared to younger cohorts. And clinicians should be vigilant about signs of alcohol withdrawal in older people, especially those hospitalized for elective surgery. Then we should always be aware that addiction treatment is not one size fits all. We have multiple treatments. We have to use them according to what fits to the patient. And the most important thing is compliance. Long-term treatment means that we're going to have a long-term success. So let's discuss some cases. We have a 70-year-old male. He's seen for routine health visit. He lives alone and has no specific health concerns. He has a history of hypertension, BPH, hyperlipidemia, type 2 diabetes controlled by diet. In substance history, he states that he does not use tobacco and consumes alcohol occasionally. When further questioned, he reports that he drinks 12 ounce of beers daily and never had more than 4 drinks in a single occasion. He has no desire to cut down alcohol use, does not crave alcohol when he does not drink, and has not a change in his drinking habit. And he has never had any effect of withdrawal from alcohol. So, which of the following will define his drinking pattern? Will it be low risk, at risk, alcohol abuse, or alcohol use disorder? You can share your answers in the chat box. Okay. So here the answer would be at risk. Since here the patient takes more than four, he never takes more than four, but continuously takes three. However, he's able to control his amount of drinking. Yet, so he's at risk of his drinking to spiral down. Then we have case two. Here we have a 73-year-old woman who's brought to the emergency because she's agitated and is confused and intermittently yells for help. Her daughter says that she's not normally like this. She lived independently at home until 2 days ago when she moved to an assisted living facility because of increased difficulty with such tasks. Then, since the move, she has displayed increasingly behavioral agitation with irritability, aggression, medication refusal, and pacing. She has a history of Alzheimer's disease, essential hypertension, and atrial fibrillation. On examination, a patient is alert but disoriented, and she's temperature is an error here, but it's about 37 degrees. Blood pressure 156/92, heart rate 117, respiratory rate 22 beats per minute, and oxygen saturation 98 on room air. On auscultation of the heart, she has an irregular rhythm with no murmurs or rubs, and normal pulmonary and abdominal findings. No peripheral edema, intact cranial nerves, and intact strength and sensation in all extremities. She has decreased skin turgor. Neurological exam shows that she has difficulty following commands with slight tremor in both hands at rest that worsens with activity. So with this patient, what should we do first? Should we start metoprolol or risperidone 0.5 or obtain non-contrast CT of the head and ask patient and family about history of substance use? Okay, so all of you answered D. The answer is D. So we should the patient, since there's a sudden change in her mental status, and it's not in a progressive. Just within the last 2 days, she developed this issue. So it could be. So we have to focus on if there is any history of substance use. So this patient most likely developed delirium. Okay, then the last case, we have a 67-year-old man who presented to the office for smoking cessation. He has tried nicotine gum patches and going cold turkey without success. He refuses to try nicotine replacement therapy again. On questioning, he says that he has depression since he was forced to retire from his job 2 years ago. He has passive suicide ideation with no history of suicide attempts or plans. Screening response showed that he has moderate depression. Which of the following would help the patient to quit smoking? Nicotine patch, bupropion, varenicline, or psychotherapy? Okay. So here the answer is B, bupropion. There was shown to be is actually an antidepressant, and it's FDA approved to be used for those to help in smoking cessation. Since the patient refused nicotine replacement, we cannot use nicotine patch. And varenicline has been shown it has a black box warning, especially for those in the elderly. And patient has moderate depression, so psychotherapy alone is not going to be helpful. Okay, so thank you very much for listening. If you have any questions, I'll be glad to help you. Put in the chat box, and I'll help you. Thank you all.
Thank you, Dr. Mohammed, for this informative presentation. Let's see if anyone have a question or if Dr. Nader have any insight before we move to the next presenter.
Great presentation. Thank you so much, Dr. Mohammed. And I think it's very important topic. So you address it well. Thank you.
Okay, so now Dr. Muna, she will present to us a topic about Kennedy ulcer. So Dr. Muna, if you're ready, you can start.
Thank you, Sam. Hello, everyone. Can you hear me?
Yes, Dr. Muna, we can hear you well.
Thank you so much. Thank you. Hello, everyone. Wherever you are, I'll be presenting Kennedy ulcer presentation today. I try to make it as concise, as informative as I can, and I hope everyone gets the most of it. Kennedy terminal ulcer. First of all, we're going to talk that the skin is a window into the overall health of the body. If read correctly, it can provide a great deal of insight into what is happening to the inside of the body. Next, doctor. Thank you. Skin breakdown in elderly. First of all, the skin becomes more vulnerable with aging. That leads to decreased cohesion between skin layers, results in increased fragility. That can lead to loss of subcutaneous tissue, results in thinning of the skin. Eventually leads to reduced activity of sebaceous and sweat glands, results in dry skin. That leads to decreased pliability and elasticity, which is less forgiving and a more cause of breakdown. Eventually, all of this leads to fragile capillaries with increased risk of ecchymosis. Next, doctor. Thank you. Skin breakdown at end of life. That's why it's called Kennedy terminal ulcer. Compounded by the following: immobility or limited mobility, incontinence, inadequate or suboptimal nutrition that can lead to body wasting, decreased cutaneous perfusion that can cause localized hypoxemia. Thank you. What is Kennedy ulcer? Kennedy ulcer, it's a terminal ulcer, were first identified by Karen Lou Kennedy Evans and her colleagues in Fort Wayne, Indiana in 1983. It is a dark sore that develops rapidly during the final stages of a person's life. Kennedy ulcers are thought to be attributable to local ischemia and skin breakdown as the body shunts blood to vital organs but their exact cause is unknown. Not everyone experiences these ulcers in their final days and hours, but they are not uncommon. While they can look similar, Kennedy ulcers are totally different from pressure ulcers. Okay, the symptoms of Kennedy ulcer. It can be hard to distinguish between a pressure ulcer or a bruise and a Kennedy ulcer at the first glance. However, Kennedy ulcers have a few unique characteristics that you can look for. First, you look for the location. It's actually located on the sacrum. The shape of it often starts as a pear or a butterfly-shaped bruise. The initial spot may grow rapidly, varies in shapes and sizes, may be observed as the ulcer spreads. The color of the Kennedy ulcer can have a range of colors similar to a bruise. You may see shades of red, yellow, black, purple, and blue. It is a later stages. A Kennedy ulcer starts to become more black and swollen. This is a sign of tissue death. The onset of Kennedy ulcer, it pops up suddenly. It may look like a bruise at the start of the day, and then at the end of the day, it can look like an ulcer. The edges of a Kennedy ulcer are often irregular, and the shape is rarely symmetrical. Bruises, however, may be more uniform in size and shape. Thank you. What causes the Kennedy ulcers? It's unclear why Kennedy ulcers develop. One theory is that the deteriorating skin may be a sign that the organs and the body functions are shutting down. Much like our heart or lungs, our skin is an organ too. As the vascular system shuts down, it also becomes harder to pump blood throughout the body. Blood can be shunted to more vital organs, and perfusion to the skin becomes diminished, which results in tissue death. How they are diagnosed. They are diagnosed primarily by exam alone. In the majority of cases, a person who develops a Kennedy ulcer will already be under the close supervision of a doctor or a hospice care provider who knows how to recognize Kennedy ulcers. However, sometimes a caregiver or a loved one may be the first to notice the ulcer. Try to know how long the ulcer has been there and how quickly it changed since you first noticed it. This information is very helpful for distinguishing between a pressure ulcer and a Kennedy ulcer. Okay, how we differentiate between a Kennedy ulcer and a pressure ulcer. Kennedy ulcer and pressure ulcers are not the same. They may look the same, but they are not, in a medical phenomenon way, the same. They appear and progress differently. Their primary cause is very different. Pressure injuries and ulcers are caused by pressure on areas that come into contact with a bed, chair, or a medical device for longer periods of time. They typically over a longer period of time, whereas Kennedy ulcer usually presents and progress rapidly. There is a test or an imaging, it's called the thermal imaging, that can be a tool that assists with differentiation between the Kennedy ulcer and the pressure ulcer. Okay. Most common sites of pressure ulcers are the sacrum and the heels. And for the Kennedy ulcer, as we mentioned earlier, it's more common in the sacrum. Okay. This is a thermal imaging. What is a thermal imaging? It's a long-wave infrared thermography systems, include infrared cameras and software for measuring wound size and thermal intensity. This captures a thermographic image, which can show a temperature pattern of the area imaged. We have two different colors, inflammation that shows up as a warmer color, which is red, hypoperfusion that shows up as a cooler color, which is blue. This can help differentiate Kennedy ulcer from pressure wounds, as they typically show up as areas of hypoperfusion. So the Kennedy ulcer usually shows a blue color, whereas a pressure wound can typically present early on with an inflammation, which is going to be a red color. Next, doctor. Thank you. How to document a Kennedy ulcer? First, conduct a thorough skin assessment and frequent reassessment, paying close attention to at-risk sites. Document time of presentation and appearance with location, size, shape, color, temperature, and how it feels. Important to note patient's condition and comorbidities. Cares implement to avoid continued pressure and skin breakdown. Frequent reassessment of the site, noting appearance and ongoing deterioration despite appropriate measures of care. Likelihood of Kennedy ulcer per supporting documentation. What can we do? Next, doctor. Sorry, they're duplicated. Okay, provide appropriate and good skincare, timely cleaning after episodes of incontinence, use of appropriate pH balanced cleanser, avoidance of alkaline products, a use of absorptive products that wick urine and stool, use of topical products that ensure supple, well-hydrated skin, routine use of emollients and moisture barriers, very dry skin, humectants like glycerin, lachydrin, and urea. How they are treated. Unfortunately, Kennedy ulcers signal the start of the dying process, and there is no way to get rid of them. Instead, treatment focuses on making the person as comfortable and pain-free as possible, depending on where the ulcer is. This may involve placing a soft cushion under the affected area. And last but not least, the prevention of a Kennedy ulcer. If patient is clearly at the end of life and death is imminent, skin breakdown is a likely unavoidable. Again, the skin is an organ, and like other organs, it shuts down and dies. However, there are things we can do to alleviate skin breakdown and or formation of wounds at the end of life. And that concludes my presentation, and I hope it was helpful. And if you have any question, I'm here. So let me know. Thank you so much. Thank you, everyone.
Thank you so much, Dr. Mona, for this informative presentation. It's the first time for me to know that Kennedy ulcer is totally different than pressure ulcer. And the difference is only the timing. Is that correct?
Yes, the timing and the process. And it was for me the first time I learned this, and it was really informative. So thank you, everyone, for listening. And I'm here if you have any question.
So, Dr. Nader, do you have any insight before we move to the next presenter?
Thank you so much, Dr. Muna. This is also a great topic and a great presentation. So basically, it's a sign that the patient is on the decline progress or projection. And why we say that? Because this nurse in Indiana in the 60s or 80s, she noticed these patients who are dying while she's taking care of them. And mostly the patients that she looked at, 50% of them died within the period, let's say, she was working with them. So she started to study the pattern. And what happened is about 50% or so, there is a figure number that when you find these ulcers, that the patients will, or this patient will die soon not necessarily everyone. So there is a 50-50 chance, let's say. And those who don't die soon, they eventually will die within, let's say, 6 months, 90% or something like that. So it's an indicator. And as Dr. Muna mentioned, you want to avoid that happening if the patient has progression that you notice. Let's say a patient with pancreatic cancer who is not eating, not doing, he is declining in general condition and dehydrated and so on. So you want to protect the skin from breaking down, or as in this case, you want to prevent as much from happening the skin failure. But it can happen, and if it happens, then you want to minimize the symptoms, or what we call the suffering of the patient. So you focus on the quality of the patient at that moment. And there is a team where they can offer this help. Some of these teams is the palliative team. And if we are talking about a patient will die soon, then you may consider asking hospice to come also on board. And the focus of these teams is to make sure the patient is having a good quality of life. If they have symptoms, they address the symptoms. And the goal is not to fix the main problem, let's say the cancer. Rather, they want to focus on, if there is pain, they will focus on the pain issue, controlling the pain. If there is nausea, vomiting, they focus on these symptoms. If that makes sense for you guys. So if you see a patient and you suspect it's a Kennedy ulcer, look at the whole picture. And if you come to the conclusion that the patient is dying, then consider palliative or hospice and focus on the symptoms management and quality of life at that moment. Thank you so much, guys.
Thank you so much, Dr. Nader.
Thank you so much.
Okay, so our third presenter is Dr. Ahd, and she's gonna teach us how to become a speaker. You can go ahead, Dr. Ahd, if you're ready.
Dr. Wissam. Hello, everyone. Let me share my slides with you. Okay. Today I want to talk to you about how to become a speaker. But the way I explain public speaking today may be wrong in 10 years. Technique change, method to capture attention evolve, and the more a trick is repeated, the faster it loses its power. But there's one thing that never changed: the reason we speak. What's the common thing between all those great speakers? Yes, they probably all have a great presentation skills, but they also had something that they really wanted to share: an idea. Across history, people have spoken for the same purpose, to deliver an idea. Public speaking is the most commonly reported fear in the general population, according to a research by Davidson in 2012. Between 40 to 70% of the population have experienced a fear of public speaking. So if your heart races and if your voice has ever shaken, that's not a weakness, that's normal. You're not alone. Today, I would like to share with you the 8 P's of public speaking, a simple framework that may help you to be guided through this journey. The first P is purpose, which is the same thing as the idea that I just talked about, and it's by far the most important element of great public speaking. If you have a clear purpose, you will find your path. Before stepping on stage, ask yourself, why am I speaking to this audience? What do I want them to leave with? Why does this need to be said now? Because purpose gives us confidence. And the biggest difference between a nervous speaker and a confident one is not only talent or experience, it's what they focus on. A nervous speaker may be focused on themselves. How do I look? What do they think of me? Is it obvious that I'm nervous? Is my voice shaking? While a confident speaker shifts that focus outward to the idea that they are delivering. When you focus less on yourself and more on the idea, you speak more naturally and freely, and then confidence follow. This was about purpose. The next P is preparation. Here you ask yourself, what will I say? Purpose matter, but it's not enough. You also need to prepare. Preparation means knowing your idea deeply, what you are going to say, and why you are saying it. Do the research, organize your thought, decide what stay and what goes. A simple rule to have is to have an introduction, a body that have your main idea, and a closure. Your introduction should start with a bang, something that grab people attention. That could be a joke, a quote, a bold statement, a historical fact, many choices. There's no single correct choice. It depends on your audience and your topic. For example, you can say, if you always do what you've always done, you will always get what you've always gotten. Albert Einstein. And then at the end, your ending would mirror that beginning. Think of it as a firework, not a fading one, but like a climax. So you might close by saying, if you start doing things differently, if you begin changing small habits, and if you truly commit to that change, you won't just hope for a different result. You will actually see them. The third P is PowerPoint. What will I show? PowerPoint is a helper, not the presenter. Use it to support your message, not replace it. A slide should inspire, not speak for you. You can use images that reinforce your story and visuals or icons that help you organize your idea or clarify it, and simplicity that keep the attention on you where it belongs. If people are reading your slide, they're probably not listening to you. So keep it simple and also like with a lot of images and so on. The 4P is passion. Why does it matter? Because if you're not passionate about what you are saying, why should anyone else care? Passion is contagious. Tell your audience why this matters to you, then show them why it should matter to them. Because people usually do not remember information very clearly, like the next day or after a few days, but they usually remember energy and inspiration. The 5th P is public. And I think this is the second most important P after purpose, because there would not be public speaking without the public. So you must know who you are talking to. A powerful presentation in like a business company would be a terrible one in a primary school, and vice versa. Great speakers do not give great talks. They give the right talk to the right audience. The 6th P is power, and this P is about you, and it has 6 components. Your power is in your words, so choose them wisely. In your voice, which have like tone, speed, and volume. It shouldn't be too loud but also not too soft. The speed is not too fast, but not too slow. And then pauses, like use them because silence is power. After you say like an important fact, you can pause for a little so that the audience can think about it. And of course, in the movement and body language and how you activate your eye contact. If you master these, you will have the power and your presence will speak before you do. So back to our 8 P's. The 7 P is practice. Practice matters, obviously. Even the best speaker rehearse. You can practice alone or with a family member or friend, a group of friends. The more you have people, the better, because like it prepare you to the actual audience you will have. Or even if you didn't have anyone or you're just a beginner, you can rehearse with a teddy bear or in the mirror. Practice turn anxiety into familiarity, and familiarity build confidence. The last P is performance. Public speaking is not reading, it's performing this idea. Step into the role of the presenter. Deliver exactly what you rehearsed, because when you walk into the stage prepared, passionate, and you present, you don't just speak. You perform. It's a performance, and you win the audience with your idea. So the next time you step into a stage, remember those 8 P's and don't just ask yourself, will they listen to me? Ask yourself if your idea is the one worth being heard. Because when an idea is important, purposeful, and alive, it finds its voice. And through you, it finds its audience and its power. So go out there and speak your mind. And this is all I got about public speaking. And thank you for your listen.
Thank you so much, Dr. Aft, for this great presentation. I believe as doctor, we all need to, practice the 8 P's to become a better public speaker. Thank you so much.
Thank you, Dr. Wissam.
Thank you so much.
Thank you so much, Dr. Ahmed. Great presentation.
Thank you, Dr. Nader.
Okay, so the next presenter gonna be Dr. Kaouthar, and she's gonna advise us on the pathway to become a U.S. internal medicine certified physician. So, Dr. Kaouthar, whenever you're ready.
Hello, can you see my screen?
Yes, we can see it.
Okay.
You can, I guess, maybe maximize it or make a full screen if you can.
Is it clear right now?
Yes, it's great. Thank you. That's
okay, welcome. So our presentation today is going to be short. Just telling you it's like a new topic coming in. The American Board of Internal Medicine, ABIM, has launched a new pilot program known as the Pilot Pathway E. So it's how to become a U.S. board certified internist without U.S. residency. So it's like shortcut or something. Why this announcement matters. This pathway represents the most significant change in certification for IMGs in decades. It expands access and recognizes international training quality. What is the IBIM pilot pathway? The American Board of Internal Medicine, IBIM, has approved a pilot program offering a certification pathway for IMGs who completed IM residency abroad. Qualification. To qualify for Pilot Pathway E, candidates must have completed a medicine residency internationally and then an ACGME accredited fellowship in the US and meet the ACGME's exceptionally qualified candidate criteria, which includes ECFMG certification, a successful evaluation by the fellowship program on core competencies and milestones, competency evaluation. Eligibility. So upon successful completion of the ACGME accredited fellowship, participants become eligible to take the IBIM Internal Medicine Certifying Examination. To sum all of that, so we have few steps. Step 1, internal IM residency. You have to pass it in your country, at your home country. Step 2, 1 year US fellowship. Step 3, you have 12 weeks competency review. It's like you will have, I guess, to pass an exam. Yes, the step 4, sit for the IBIM internal medicine exam, and then you'll have you will become a board certified internal doctor by passing the IBIM exam. And you have the step 6, which is optional if you want to subspecialize. You just have to pass the subspecialty board exam based on the chosen fellowship. So the same fellowship you had the year you had it in step 2. Retroactive rule. So retroactive eligibility back to 2016. So any physician who completed an ACGME IM fellowship since July 2016 is eligible immediately. So you can apply. So all of these fellowships are eligible, such as cardiology, gastroenterology, pulmonology, nephrology, endocrinology, hematology, oncology, geriatrics, rheumatology, infectious diseases, and more. So basically all the medical specialties. No US residency required. The pathway bypasses the usual requirements of completing a 3-year US internal medicine residency. Duration. IBIM will evaluate outcomes over 5 years before deciding whether to continue or expand the program. So the program is continuing for 5 years from now. So it should be ended. They should evaluate it through 2030. International recognition. So training completed in Canada or ACGME international programs qualifies. So either completed in your home or in Canada, but just once you complete your training at home, you just have to go through the ACGME international programs. But the Canadian training equals to the American one. Application status. It's open now. Eligible physicians can apply immediately through IBIM official website. Benefits. Why this is a game changer? It's a shorter path to certification instead of repassing the 3 years residency. Reduced costs for even for the hospitals, because they won't have to pay you as a resident learning doctor. You just have to go through this exam and pass a year of fellowship, and then you are a certified doctor who is eligible to practice your job there. Easier entry for IMGs, recognition of global training, expanded physician workforce. So to expand physician workforce, because they are in need of doctors right now. Who benefits? Who should consider this, by the way? IMGs with prior IM residency, current fellow, past fellows since 2016. As we said, since 2016 you are eligible, internationally trained specialists. So we have to compare the traditional pathway to the new one. We can say that the traditional had three major steps compared to the 3 major steps in the new one. The traditional pathway consists in passing the USMLE exam, and then you have to match, and then you have to go through the 3 years residency as the same as the US students do. International, whether for the new pathway, just you have to go through the international residency at your home country, for example, plus 1 year fellowship. You have to do it in the US, and the IM to go through the IM boards exam. Future outlook. IBIM will assess candidates' success, exam performance, and program credibility before renewal. Knowing that. Resource. Okay, the resources IBIM website. This is a resources. I hope everything is clear. Do you have any questions?
Thank you so much, Dr. Kaouthar, for this very informative, talk, and it's really a game changer for international internists. Thank you so much.
Thank you, Dr. Kaouthar. And this is also a great presentation, and it's a great topic, and it's on time. And hopefully it will help some of you guys or those who already did their internal medicine training, and maybe they did. Yes, go ahead, Mounira.
Yeah, thank you so much. So for this pathway, does it also take on consideration the one who did the residency directly without internal medicine? Because in my country, for example, we're doing the residency without passing through internal medicine. For example, endocrine, HMO, or other specialty. Is this taking care or not? Taking on consideration, or not?
I'm not quite sure. They mentioned the internal medicine in their requirement, but I think you need, if you did training, you need to show them your training, and then they can qualify or equate and see if it meets the requirement as far as the details, like
Thank you
they
so
have.
much, Dr.
Thank you. Sure.
If I might add something,
Oh, yes,
according to
please.
what I've read about the subject, so it doesn't have to be like a NIA, because in some of our Arab countries, we don't go to IM residency in all the medical fields. So, for example, gastroenterology, if you have the gastroenterology, you've passed the gastroenterology residency in your country, you can apply as an it's considered as an IM specialty over here. So you can apply through it and see your check for your eligibility about that.
Thank you so much.
Thank you so much.
Okay. So now, Dr. Mounira, you're gonna talk to us about, or teach us about the new position as a house physician here in US. So yeah, you can start if you're ready.
Yeah, I guess that, but I didn't prepare any presentation or so I didn't
No
know
worries.
about that. So the thing that about the house physician, it's not new. Maybe it's for us, it's new, but there is someone who did it like 7 years ago, or I think more. So it's a limited license. I think it's not only in New York, but the information that I have, it's in New York. But there is many other states, they already accept to like do the limited license for the international, like the IMG doctor. So for this one, it's you can work as a physician, but with limited like license and under the supervision of another internal medicine or other doctor. It's the medical director. Actually, I'm working as a house physician in a nursing home in Albany. I think most of the job this company it's doing with the nursing home. So, but I think there is many other company they could do it with nursing home. I know that there is some also other do it in like some hospitals. It's not obligatory to do it in the nursing home. How I found this job, it was through LinkedIn. So it was like a coincidence. After the last year, the result of the match, I look after this house physician or limited license. I found this company. The name of the company it's Partner Care. I contacted the owner by message through LinkedIn. He answered and asked for the CV. After he reviewed the CV, he gave me a interview. After the interview, they accept me. After they offer you the job offer, they will send you with that some form. This is the form that with it you're gonna apply through the New York Education in Albany through mail. I think now also they do it through email. So you're gonna send the paper that the company sent it to you with other form. The form name it's 5B. You will fill out like your name, that you are CFNG certified, and also what's everything you did it from your graduation until today, until the day that you're applying for. The other thing you need also to do a verification through SMB, the one that we usually do with the account for the step 3. So you will do a verification with them. It's cost I think 600 something, and the application for the license it's cost $105 or something like that. Then you're gonna wait. It depends. I think it depends the season, and also it depends from where you are coming, because most of the people working here are Bangladesh people. So usually the Bangladesh people, I think it's like more short because they used to do it. Or for my case, it's took me like 3 months almost to get this license. Then you will start, they will teach you for a week or about the system. It's not about medicine. You need like to have some experience to manage patient. Most of them are elderly patient. Then I see like it's a great opportunity to learn and to add in your CV. It didn't help me to get interview. Yeah. Anyone have any questions? So this is in general. If like you need any more information, please ask me.
Thank you, Dr. Mounira. I have a question. So,
Sure.
how long can you practice under this license?
So it's 2 years, then you can renew it for another 2 years. Then that's it.
Okay. And then also, what type of clinical experience do you think they require from your home country?
So for this one, they didn't require. They require only step 1, step 2, and be certified, ECFMG certified. They even don't require the step 3. So you can do it without step 3. But once you show them that you have some experience, that it's gonna great for them, because after that they need someone who have some knowledge, like who's already worked or.
Okay, thank you so much.
Okay.
Any other
I have a question. Yes, please. I have a question. Yeah, Dr. Mounira, do you think this pathway will end by unlimited license?
Well, I didn't. Do you think? That's what I think.
Sorry?
I didn't hear your question. Could you please repeat it?
Yes. I heard in Washington they have same program, but after 4 years they work that the program will be limited. Yeah, so will be lead to unlimited license.
No, it's not in New York. Yeah, this is its difference. And that reason, this is in New York. I think it's not good. It's not only Washington. I think many other states, they can give you the full licenses after 2 years. I think there is some of them. But in New York now, you can renew the limited license again for another 2 years, then that's it. Sorry for the background, because my daughter is next.
Thank you, doctor. Thank you.
You're welcome.
Dr. Mounira?
Yeah.
Can you share with us, can you write to us the name of the program or give us the link in the chat so we can...
It's not a link I can give you. It's Partners Care.
Wagner?
Partners.
Okay. If you write it, please, in the chat.
I will. I'm doing that.
Appreciate it. Thank you.
Yeah, there is someone, Dr. Nader wrote it, yeah.
Okay.
Sorry.
Appreciate
Thank
it.
you so much, Dr. Nader. Any other question?
Go ahead. Anyone else? Any questions? Thank you so much, Dr. Mounira. Any other questions?
My pleasure.
Okay. So if there is no other questions, the last part of the day is the project update.
So if anyone wants to tell us anything about your updates, project progress, and if you have any ideas for research projects, or if you have interviews or any news to share. So I'm gonna share with you good news. And I'm gonna share the screen. Oops. So I have got emails from 2 of our fellows, Dr. Abdullah and Dr. Zeinab. Both of them matched, and Dr. Abdullah, he is a fellow with us for a few years now, and he was matched to a residency program in family medicine in Allentown. That's St. Luke's University Hospital in Philadelphia, or near Philadelphia in Pennsylvania. So congratulations, Dr. Abdullah. I don't believe he is with us in this meeting now. And the other one is Dr. Zeinab Mohammed, and she matched to nephrology fellowship in Detroit area. And we would like to also extend our congratulations to both of them. So, any one of the new fellows in this group today?
Yes, Dr. Nader, there is one new fellow. I guess he put a question. She wrote down, I just joined today. what and how to contribute as someone new?
Excellent question. So go ahead, Dr. Osam, answer that question for me.
Okay, so Dr. Lujane, we have a weekly meeting every Saturday. We have like great presentation like this. You can participate as a presenter. Also, you can. There is also an opportunity to develop a mobile app. There is a lot of also like previous recordings about how to be able to do the mobile apps, and also a YouTube channel with can also give you like some information about previous sessions. Also the Dr. Nader mobile app shows like projects you can involve in, you know, participate in research, although I didn't participate yet in any. Yeah, and also you're gonna be under a leader, and she can guide you more and give you opportunity to do like presentations and other activities. Sorry if I missed anything, Dr. Nader.
No, that's you summarized it very well. So please, would like to welcome you, Dr. Lujane, first of all. And as Dr. Wissam mentioned, these are some of the steps that you may need to do or participate these ways. So basically, what I want from you is to look at the app where you would like, you will find. I'm going to share the screen so that you can follow me when I'm talking. Basically, the app that we shared with you, it has many resources, and we started this fellowship in 2020, so almost 5 years now. We recorded our meetings, and most of the fellows in this program participated either by presenting some of these topics and creating more topics, or coming up with new ideas or topics, or current topics, or topics of interest for them. So basically, we want you to learn from what the other fellows are presenting, but at the same time, we want to offer you an opportunity that you can teach us if you have some knowledge or experience in certain area, or if you want to practice your public speaking as presented today, or share some of the current information or current event. For example, we are interested in artificial intelligence and how to develop mobile app for patients. So these are current things that we think it might be of help to you when you apply to residency, or to your patients if you are dealing with some patients in certain areas. So the first section here is where we keep our updates. Like if you want to, this is a conference will be coming soon. If you want to participate in a poster presentation, you can work on a project about some of the topics that we plan to submit to this conference, for example. This is how you want to develop an app. Simple steps you can follow. If you want to improve your CV or your resume, there are some courses that offered by Harvard and other elite universities or programs, so you can add to your CV and so on. So this is just like a notification or announcement. Then you come down, this is where the meetings, if you go to the upcoming meetings, next week we will talk about these topics and so on. So if you're interested in, let's say, presenting or be a part of a team that present a topic, each topic can be presented by one fellow or more than one fellow. Let's say you are available December 20, 7, and you are interested in talking about nutrition in older adults. So Dr. Ayat will be presenting, let's say, on that day. Maybe you can reach out to the team manager or team leader that day and Dr. Ayat and see if you want to share that topic together. So Dr. Ayat might present the first half and you will present the second half also. Or if you want to present a topic by yourself, let's say you have a good idea about EMR and EHR, so maybe you can reach the team leader for that day and tell them, I want to volunteer to present this topic number 3 about the electronic medical records and so on. Some of these topics, if you click on the details, you will find the topic and some of the presenters. But if you go down, some of these will have resources like teaching slides that were made by the American Geriatric Society or other fellows in this program, or we obtained from the internet how. So basically you will download the, let's say if Dr. Mohammed was presenting about addiction, the slides about that topic was present, can be found in this link. The second topic, Kennedy ulcer by Dr. Mounira, the topic also has some slides on this. If you want to reach out to the follow, let's say last year we talked about something, let's say TED Talks, and you want to get that information, look at the contact number for the fellow who presented that topic and be in contact with them. And they may have their own slides. We don't have it here, but you can reach out to the person. And to find out about the person, you can either go to the fellows. So you will have junior fellows, senior fellows. You can reach out. You will find their contact email or phone number and so on. Then if you want to start a project, you can come up with a new idea. You can add it to our project list as a new project. Or if you want to start with a team that's already working on a project, then you can look for which topic that interests you. You have a list of almost 100 topics or so. So if you want to work on telemedicine, for example, you might have some enhanced accessibility, for example, TikTok or other impact of telemedicine on healthcare. So if you want to add yourself there, you can just add me. You can talk about or read about the project. And then down there, you will find some of the team members of that project. You can reach the team members or leader or project leader for that topic and see how far they are in the process and how can you participate and help them finish that project. You can keep track of your progress, and when it's time for you to request a letter of recommendation, you can use this, and you can update your task list of what you did. Number 1, I presented this. Number 2, I participated in this project. I developed this app, whatever. So for me, when I get your request, I will come and look at, hey, Dr. Omar, for example, or Dr. Naud wants me to write him a letter. So he has a list of what actually he participated in during his stay with our fellowship. So I can make the letter personalized upon taking of this experience that he had with us. So when the program director or during the interviews, they ask him what he did, or if they have a special interest of a topic, they can say, hey, you have an abstract about e-cigarettes. Can you tell us about your participation in this? So he or she can talk about that as well. So this program or this app will show you a lot of stuff. The curriculum is basically, we want you to go over this objective of the program by the end of, let's say, 1 year or 2 years, or however you spend with us. We want you to know more about the research part. These are the items. But in addition to that, we want you to either learn more to improve your skills and quality as a physician, as a leader, as a teacher, with organizational skills, with leadership skills, and with any other skills that may be needed in the future to help your patients, to help your students, and so on. We know that some of you might have already some experience, research experience, and some might have little or none. So those who don't have enough, we say these are early research experience fellows, and we expect them to learn, as we said, some of these objectives. If you have some, we may say you have reached the middle experience, where you can have some experience where you can share your experience with others, or you can teach some others. Let's say you participated in writing a poster, or you know how to design a poster. So you have some background or experience, and you can tell your team that I know this, so I can help you with this, and so on. And late experience or late research or knowledge about what skills you have. Some of you might have master degree or some degrees where you applied and you have a good experience of, let's say, using SPSS. This is a statistical program, or other reference management program, if you wrote a manuscript and submit it to the journal. So you have good experience of doing a project from A to Z, then you might also teach others about how you did that, how it's done, how to make other fellows in the early phase or middle phase to reach your level of experience. So it's kind of a two-way program for each one of you to give us and take. So if you have any type of thing that you want to share and teach others, this is a good opportunity for you. If you are just finished your medical school, we expect you to learn. So other fellows will help you learn whatever aspect that you need to improve on. We have seniors and we have new fellows. So you reach out to the seniors and they can guide you to the right way, or what if you need some resources. Some of them might have good idea about how to do, for example, systematic review or writing a case for a conference. Let's say you want to submit an abstract and present it as a poster in a conference. Then some of the fellows who presented in the past, they can teach you or guide you as far as how to do it the right way. Similar to if you want to submit a manuscript, how to write it from A to Z, how to go to the website that help you identify which journal that you want to submit. If you know all this, that would be great. If you don't, then the seniors will help you. Okay, there are a lot of stuff that we have in this program, but take it slowly and search and browse around. You will have a team leader list if you want to reach out to other team members and see. We divide them by specialty, by country. So if you live in a certain state or area or country, you may want to reach out to fellows near you and make connections that way, see what they are doing. and how you can help them, or they can help you, or you can work together. This is the list of those who matched last year. For example, you can reach out to see if you want to have answers to some of the questions about the interviews or residency, their first year, how did that go, and so on. If you are interested in a specific area, there is interest group, like if you only wants to apply, if you want to apply to pediatric, for example. So there are a few fellows who are also interested in pediatrics, so you can work together on a project that involve pediatric population, or if you are interested in neurology or psych, whatever you might be interested in. So this is just a brief introduction to using this app and using the communication with other fellows, if that makes sense. I'm gonna stop here and see if you have any questions.
Hello, Dr. Nader and everyone. I want to apologize. I couldn't participate today, and I want to thank all the presenters and thank you for Dr. Wissam because she covering me.
Thank you, and we are glad to have you, Dr. Zeinab.
Thank you, Dr. Zeinab, for this opportunity. And sorry, Dr. Nader, for not being able to, deliberately talk about the program, this great program.
No, I wanted to show her. So I just wanted to let you guys share, because you already went through the steps, and it might be easier or makes sense when it comes from one of you to show the new fellows how it's done or whatever. And I just wanted to add a little bit background. So you did a great as far as answering the question, I think. Let's hear from Dr. Lujain.
Thank you so much. Dr. Lujain, do you have any question?
If you don't, any other fellows in this group, if you are working on a project, or if you have a new idea about project, or in general, if you have questions about the program or how we can help.
Dr. Nader, hello.
Go ahead, Dr. Ahad.
About the research idea, the meta-analysis that I talked to you about in the email, should I add it on the app in the new project section?
Yes. So what we do is, I'm not sure if you have a team. Do you have a team?
Yes, I am the
Okay.
silver team leader.
Okay, no, what I meant, so I'm gonna explain to Lujain as well. So we organize the fellowship on a team-based approach, where we have teams by colors. This is just for organizational task-based approach. Like when we talk about today's topic, we want some people to only work on this, and the team will be assigned to this presentations, so the leader can help or organize, and these fellows from the team can present. And if we don't have enough fellows available to present, then they will talk about the topics, or opportunity for other members to chip in or to volunteer to present. So not necessarily the team that's assigned to the day only present, for example. So if you are from a specific team, and next week is a presentation about a topic that you are interested in, you can approach the team for that day and see if you can volunteer. And as I said, the topics can be presented by 2 or more. So this is just a way of organizing the program between you guys and give you an opportunity for every one of you to get a chance to present and interact and so on, organize and maybe be a moderator for the meeting and see how things are done, do it yourself. So it's just organizational for the program to be going on smoothly. And Dr. Marwa is helping me with that. The other organization piece, which is the project-based approach, I'm gonna use Dr. Aht project as example. So Dr. Aht came up with an idea, let's say a topic about certain things. She will tell us about the topic. Then she will post that topic either in the app or she can present it to the big WhatsApp group, say, I'm interested in carrying or starting this project about whatever. If the topic she's interested in is an idea to present in a conference as a poster, we call that an abstract. So the project will be about an abstract, and that project will have a number of fellows. We expect the number to be less than 10, and that's because most of the conferences, they have limited number for the authors. So if the team for the project has more than 10 fellows, some of these fellows might not be listed when they are submitting to the conference. And we had this problem in the past, and it's not fair for the fellows to work on a project and then their names will not be submitted, if that makes sense. So to avoid that, Dr. Aht, for example, can say, I need 8 people to work with me. If she got 5, that's well and good. But if she gets 20, then in that case, what we do is we ask the 20 to work on 2 projects. So they divide so that they can have an opportunity to work on the project and a good chance of presenting that work at the conference. So this is about the project approach, kind of, and we call the fellow who's leading that project a project manager. Let's say Dr. Aht is available to work on that, so she will assign the fellows and some of the tasks. So now if she has 8 fellows, she will say, we need to work on this. These are the 4 tasks. So 2 of you will do the first task and 2 of you will do this and whatever available. So it's just organization between that team that's working on the project. Sometimes people might have available time difference. Let's say I want to study for step 3 in 4 weeks. So I can not participate during these 4 weeks with Dr. Aht, but I'm really interested in joining our team and working with this project. So what I'm gonna say, can I just participate at the end or after I take my step 3 test in a month? So she can accept you in her team, and then in a month, she will assign you the task of doing the last steps or task of that project. Let's say if they want to submit to a conference, so you will be the one who is organizing the final abstract, submitting it, communicating with the conference, and if the abstract is accepted, maybe you will be designing the poster and so on. So this is just the manager of that team will assign the task and make sure everything is smooth and everyone is involved and so on. And let's say, no, she is working on a manuscript. Her idea is to submit a manuscript to a journal, so it will be published as a paper. In that case, the same approach. So we will have a limited number depending on what journal she will approach. But if the topic is important, then we don't have limitation of number of authors or volunteers or fellows in her project. Because if you look at some of the journals, some of the topics are very important, and the authors, more than 20, more than 30 authors for that topic, because it's significant, and the journals will accept the topic or the article with all these authors in the list. So it depends also on different factors. But the fellows will join Dr. Aht in her team, and then she will assign the same idea. If she is writing a systematic review, she will assign some fellows to write the approach or the methods part of what we are going to do. Some will take the first step of writing the background or getting the information, for example, and then some will work on the search part and collecting the data, some analyzing the data, some finalizing the conclusion, and maybe some will be putting all together and submit it to a journal. And one might be the corresponding author, so they will be in contact with the journal as far as submitting. If there is a review, they will take the review input from the reviewers, and then add, edit, or change whatever is needed, and then resubmit and see. And it's going to be back and forth with that journal, for example. And if it's accepted, that's well and good, then they will congratulate each other. If it's not accepted, then that corresponding author, maybe they will find another journal. But now they will make some changes to match the new journal and resubmit it to the new journal and so on. So this is how it's done. So Dr. Aht will be the manager for that project, if that makes sense. If it is an idea for a mobile app, then there is no limitation as far as how many fellows will be included in the development. So if you have an idea of developing an app, you can share that in the WhatsApp group, and whoever is interested in that project or that mobile app development, they can participate. Some might have no idea about developing an app, which is okay. Some might have a little bit of an idea. Some might have experience, like they already develop an app or has teams who develop an app in the past. So no matter how your skills in developing an app, you can join the team and you can learn, you can participate. The process is the development of the app nowadays with AI is very, very quick, very simple. You just need to have an idea about what you want to do, give it as a prompt to the tool or some of the AIs available, and it can create the app for you. What you need from other fellows is to test that app and see if there is any room for improvement. You want to increase the font, you want to make it in a different language, you want to add this color, that color, and so on. So the other app fellows will help you, if that makes sense. And then if you finish the development, you can submit it to Google Play Store or Apple Play Store, and then publish it as a mobile app, and you can use it for your patients. Dr. Aht, sorry, I stepped on your toes, it seems, but do you have any question, Dr. Aht, or any other fellows?
Thank you, Dr. Nader. Thank you so much. I don't have any question.
Yeah, and you can add it to the app as well, and people can join you there as well. So it's just an organizational step for you guys.
Okay, thank you.
Thanks. Any other questions or ideas or anything for the program itself that we can change for new fellows or you in the future, that you want any features or any things that we make it available for you guys? If not, I'd like to thank you all for attending this meeting, and thank you, Dr. Sam, for moderating the meeting, and all the presenters from today's meeting. Thank you so much for great presentations, and hopefully this will help others. And for those who will watch the recording in the future, thank you in advance. Have a wonderful day, and thank you. Nice seeing you all today, and we'll see you next week. Assalamu alaikum.
Alaikum salam. Thank you so much.
Thank you so much, Dr. Nader.
Thank you so much, Dr. Nader. Alaikum salam.
Alaikum salam. Thank you so much.
Yeah,